This section is going to be concerned with calcium regulation and the pathophysiological consequences on the bone. So calcium metabolism is closely linked in with the metabolism of two other ions as well, which includes phosphate and magnesium. Three hormones interact to control calcium metabolism. These include PTH, vitamin D, and calcitonin. We'll cover each of these hormones in detail in this section. And it's also important to note that calcium regulation is actually considered to be a very high yield topic for step 1. Primary regulation of calcium is by PTH. PTH is made by the chief cells, which are in the parathyroid glands. And its primary role is to raise serum calcium. And PTH does this by 3 mechanisms. 1, it acts on the bone to increase bone reabsorption. It acts in the kidney to increase absorption directly, and also stimulates the kidney to activate vitamin D. And thirdly, it allows for the absorption of calcium from the diet by activating on the intestine. It is important to note that PTH also increases renal phosphate excretion and therefore decreases serum phosphate. And high phosphate levels by themselves can promote PTH release. But the key inducer of PTH release is low calcium. There are specific channels in the kidney that help reabsorb calcium directly, and these are PTH-sensitive calcium channels as illustrated schematically in this slide. Consequences of parathyroid hormone dysregulation can be manifested as either hypoparathyroidism or hyperparathyroidism. In this slide, we'll first talk about hypoparathyroidism. Biochemical manifestations of the low PTH state include low serum calcium, high serum phosphate, and also sometimes the presence of osteosclerosis or thickened bone. Low serum calcium can be manifested physically in terms of physical signs as a Chvostek sign or a Trousseau's sign. One important point also to keep in mind when considering hypoparathyroidism as a diagnosis is pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism, as the name suggests, is not true hypoparathyroidism in that PTH is not truly low. In fact, PTH levels can be high or normal. And the reason for this is because of a defect in the sensitivity of sensing PTH or PTH resistance. And the reason for this is because of a mutation on a G protein coupled receptor called a GNAS mutation. But the end result is nevertheless hypocalcemia. So both true hypoparathyroidism and pseudo-hypoparathyroidism result in hypocalcemia, but the PTH levels in the two states are dramatically different. In true hypoparathyroidism, PTH levels are low. In pseudo-hypoparathyroidism, PTH levels are normal or increased. And as a result, symptoms are not improved in pseudo-hypoparathyroidism by the administration of PTH. This question deals with some more specific regulation of PTH itself. 60-year-old woman has a serum calcium of 7, which is low, serum potassium of 2.8, which is also low, and her PTH concentration is decreased. The decreased PTH is most likely related to a severe depletion of which of the following ions? And the correct answer here is C, magnesium. So as I said in the beginning of this section, there are 3 ions that are closely interlinked: calcium, phosphate, and magnesium. As it turns out, magnesium is critical as a cofactor for the action of PTH. So for PTH to really work well, the serum magnesium concentrations have to be appropriately in the normal range. So in this case, there is low PTH likely because of pronounced hypomagnesemia. So the appropriate thing to do in this case would be to correct the magnesium first, which would then correct the PTH, which would then likely bring the calcium back up. And quite interestingly, it would also correct the potassium levels. The other consequence of PTH dysregulation is hyperparathyroidism. And as shown here in this slide is the consequences of the manifestations of primary hyperpara. Biochemically, the main driver here is an increase in PTH. So the increase in PTH can be happening because of either parathyroid adenoma, which is about 85% of the time, or parathyroid hyperplasia, which happens about 15% of the time. The net result is However, an increase in serum calcium, decrease in serum phosphate, and also possibly increased formation of the 125 form of vitamin D, because PTH is responsible for the activation of vitamin D in the kidney. Clinical signs and symptoms are consistent with those of hypercalcemia, which includes renal stones, depression or psychosis, bone reabsorption, which results in a classical PTH manifestation called osteitis fibrosis cystica, which is a very classical primary hyperparathyroidism feature. And in addition, there are other consequences that can include pancreatitis as well, which is as a result of hypercalcemia. So again, take-home points here are primary hyperparathyroidism is initiated by an increase in the PTH itself. And the increase in PTH can be because of an adenoma or a hyperplastic response in the parathyroid glands. This question allows us to better understand the relationship between serum calcium concentrations and PTH concentrations. So this diagram shows 5 disease states in which the calcium and the PTH relationships are shown. The question is asking which of these is consistent with chronic renal disease. And the correct answer to this question is A, which is showing low calcium and a high PTH. And in chronic renal disease, you have hypocalcemia as a primary feature of the disease itself, which then secondarily releases PTH from the parathyroid glands. So the parathyroid glands are responding to the low calcium by increasing PTH levels. That's classic secondary hyperparathyroidism. Option C is depicting what the normal ranges of calcium and PTH are, whereas B shows primary hyperparathyroidism, where you have a high calcium and a high PTH. So indeed, in this case, it is the high PTH that's driving the high calcium. Option number D is consistent with primary hypoparathyroidism, because you have low calcium and low PTH, and again, it's probably the low PTH that's driving the low calcium. And then finally, option E is consistent with hypercalcemia, but it's non-PTH mediated hypercalcemia. As you can see, the hypercalcemia appropriately suppresses the PTH, which is a normal physiological response. And in this case, the hypercalcemia is caused by diseases that are unrelated to PTH, such as hypercalcemia of malignancy or sarcoidosis or another process that is independent of PTH. So again, going to some more details about the secondary causes of hyperparathyroidism, the main causes are chronic renal failure or vitamin D deficiency. The main differentiating biochemical findings between the two is the phosphate levels, because both of them have low calcium. So it is the low calcium that is driving the PTH, but the phosphate levels are variable depending on whether it's chronic renal failure or vitamin D deficiency. In chronic renal failure, phosphate levels are usually high, and vitamin D deficiency, phosphate levels are often decreased. Which brings us to the second hormone that regulates calcium metabolism, which is vitamin D. We get most of our vitamin D from the conversion from the UV light of the sun rays, where the UV light activates 7-hydroxycalciferol in the skin, and through a series of reactions we end up with 25-hydroxy D3, which is the storage form of vitamin D in the liver. And this storage form gets converted to the active form in the kidney by the action of PTH. So PTH is important for the conversion of 25 to 125 vitamin D3. And the enzyme that does that conversion is 1-alpha hydroxylase. Important points of similarities and differences between PTH and vitamin D are the following. Like PTH, vitamin D3 also increases serum calcium by affecting osteoblasts, so it enhances bone reabsorption. It also promotes gut absorption of calcium and phosphate, so it increases calcium from absorption from the diet. But unlike PTH, vitamin D does not promote renal phosphate wasting. It does the opposite, in fact. Therefore, the net consequence is an increase in the serum phosphate. So vitamin D deficiency results in decreased phosphate, and vitamin D excess results in increased serum phosphate. Here's another question that tries to highlight the actions of vitamin D. 25-year-old woman who has had generalized bone pain for 9 years. She's had frequent episodes of loose, bulky stools. Examination shows muscle weakness and distended abdomen. X-ray shows a generalized demineralization of the bones, absence of the lamina dura, and fracture-like lines in the bones of her feet. Which of the following sets of findings is most likely in this patient? So this whole constellation of findings that are being described in this question is highly consistent with vitamin D deficiency, and vitamin D deficiency in an adult is called osteomalacia. So vitamin D deficiency, as I said before, results in hypocalcemia. So look for a situation that causes low calcium. And as a consequence of the low calcium, you have an increase in the PTH because it is secondary hyperparathyroidism. But vitamin D deficiency also causes low phosphate, so phosphorus levels will be low. And because vitamin D deficiency is considered to be a high bone turnover state, it also releases and causes an increase in the activation of alkaline phosphatase, which is a marker of bone turnover. So the consistent answer here for all these findings would be A. So the A is the correct answer for this question, which causes the low calcium, the high PTH as a consequence of that, low phosphorus, and then a high alkaline phosphatase. So the manifestations of vitamin D deficiency can be osteomalacia in adults, and it's called rickets in children. Rickets is characterized by softening of the bones, bowed legs, fracture-like lines called the loser zones, and enlarged liver and spleen, profuse sweating, and the other constitutional symptoms of listlessness and insomnia, and generalized weakness. In adults, the same disease is actually called osteomalacia, and it's caused by pronounced vitamin D deficiency and characterized by deficiency in the bone matrix mineralization. So these bones look more translucent than they ought to be because the mineral in the bone is not present anymore because the vitamin D is not sufficient. Vitamin D deficiency can also be caused by not only rickets can be caused not only by a pure lack of vitamin D, but also by end organ resistance, so vitamin D resistance. And the only differentiating factor between vitamin D deficiency and vitamin D resistance is the actual concentration of plasma vitamin D itself. So obviously in deficiency, those levels will be low, but in resistance, vitamin D levels are in fact increased. Whereas the rest of the biochemical profile is identical, because in vitamin D end organ resistance, the vitamin D is present, but it's not able to get activated or respond in terms of its receptor, and therefore the downstream events of plasma calcium, plasma phosphorus, urine calcium, and urine phosphorus are all the same as absolute vitamin D deficiency. This question is describing an elderly woman who has had generalized bone pain, loss of height over the last 5 years. Complete blood count is normal. Serum protein electrophoresis shows no abnormalities. X-ray shows generalized loss of bone density and a compression fracture of T8. Which of the following is most likely to be present in the biopsy of the iliac crest? So first of all, the diagnosis here is osteoporosis. And the clues that will tell you is the loss of height and compression fracture, which is very typical of osteoporosis, and the most common and the most sort of quantitative finding is really the generalized loss of bone density. So she clearly has osteoporosis, and the underlying pathophysiological feature of osteoporosis is thin trabeculae with high osteoclastic activity, which is number D. So the correct answer is D, thin trabeculae with high osteoclastic activity, a hallmark feature of osteoporosis. Sheets of plasma cells, option number C, is consistent with multiple myeloma, but they tell you that the serum protein electrophoresis is normal. Disorderly osteoblastic and osteoclastic activity is a feature of another bone disease, which we'll cover next, called Paget's disease. And cysts filled with fibroblasts and giant cells are usually a process associated with any of the bone tumors or bone overgrowth, and commonly osteosarcoma. Osteoporosis is an overall decrease in the quantity of the bone itself, so decrease in bone density. And as shown in this slide, you see that there are lots of holes in the bone matrix, and normal matrix should be ossified nicely, whereas in osteoporosis, those bone matrices are thinned out because the density of the bone is decreased. The mineral to matrix ratio is normal, but there are lots of unfilled lacunae. And osteoporosis may occur oftentimes in females after menopause because estrogen is a very important hormone that maintains bone mass. but also it could be seen in patients who are treated with excessive glucocorticoids for a long period of time, or in patients who have been immobilized for a long period of time, such as people with fractures of the long bones, or even astronauts who have been in long space flights who don't have weight-bearing activity to maintain their bone strength and mass. The diagnosis is often made by using a DEXA scan. Treatment is by trying to replete the vitamin D and calcium, but also by stabilizing the osteoclastic activity by using bisphosphonates. And certainly in the case of postmenopausal women, estrogen therapy has also been proven to be successful. This question is depicting a 67-year-old woman who comes to the physician because of an 18-month-old history of progressive persistent left hip pain. She has become hard of hearing. She's also had 2 kidney stones. She's had pain in the long bones. Serum calcium and phosphorus are normal range, but the serum alkaline phosphatase is markedly increased, and so is the urinary hydroxyproline. Which of the following is most likely the diagnosis in her case? So this case is the case of Paget's disease. So there are several features here that will tell you the classical features of this disease. One, this is an elderly woman, so Paget's disease is a disease oftentimes of the elderly. Hard of hearing is an important clue because Paget's disease that involves the skull can be certainly involved with hearing problems. And the 2 biochemical hallmarks are increased serum alkaline phosphatase and increase in the urinary hydroxyproline, both of which are markers of high bone turnover. Again, like vitamin D deficiency, Paget's disease is also a disease of high bone turnover. So the correct answer again is A. So this is what Paget's disease looks like. So it is characterized by disorderly or abnormal remodeling of the bone, where there is disorderly osteoclast and osteoblast activity, and that ultimately results in a very thickened cortex. But even though it appears to be a thickened bone, the bone structure itself is weakened. It's not a very healthy bone. And as a result of that, it may be causing substantial hip pain, deformities, especially in the elderly. If the disease involves the skull, it can often lead to cranial nerve compression and hearing loss, as we saw in the case of our patient in the last question. And the other important point to remember about Paget's is that it does not spread to other bones. It's usually unilateral. The laboratory hallmark, as I said, is a high bone turnover state manifested by increased alkaline phosphatase or increased urinary hydroxyproline. We really don't know what the cause of this is. And the treatment, again, to control some of these pain symptoms is bisphosphonates, because it helps to really stabilize the osteoclastic activity. Finally, the third hormone that is involved in the regulation of calcium metabolism is calcitonin. So calcitonin is in fact made in the thyroid, but it's made by the thyroid parafollicular cells. Just to put this in perspective, thyroid hormone is made by the follicular cells. Calcitonin is made by the parafollicular cells. And it's primarily made in response to a high serum calcium level. So the job of calcitonin is to really tone down the calcium. So if there's a lot of high calcium, calcitonin goes up to bring it down. And it does that by inhibiting osteoclasts and also by inhibiting renal tubular absorption of calcium. Calcitonin also decreases serum phosphate by inhibiting its renal reabsorption and thereby increasing its excretion. So let's try to summarize the 3 different hormones that regulate calcium, as shown in this last slide. So again, there are 3 hormones: PTH, vitamin D, and calcitonin. They all work on regulating calcium and phosphorus levels in the blood. PTH and vitamin D, both of them increase serum calcium, whereas calcitonin decreases serum calcium. PTH decreases serum phosphate, whereas vitamin D3 increases serum phosphate. Calcitonin also decreases serum phosphate. In terms of the urinary regulation, both PTH and vitamin D3 decrease urine calcium, whereas calcitonin increases urine calcium. And finally, PTH increases urine phosphate excretion, whereas vitamin D3 decreases urine phosphate excretion, and calcitonin, like PTH, also increases urine phosphate excretion. But the important points to remember here are that there are 3 hormones: PTH, vitamin D, and calcitonin. And all three of them are responding to serum calcium levels to try to maintain calcium in the homeostatic range. The take-home point again in conclusion of this section is that each of these hormones can lead to perturbations in the physiology. So if you have too much PTH, it leads to hyperparathyroidism, which can be primary or secondary, and or hypoparathyroidism if there's too little PTH. Vitamin D, on the other hand, often leads to vitamin D deficiency, which is a more common manifestation as opposed to vitamin D excess. And vitamin D deficiency in kids is called rickets, and in adults it's called osteomalacia. And finally, calcitonin is the main job of calcitonin is to tone down the levels of calcium to bring down calcium levels in response to excess calcium. This concludes the section on calcium and its effects on bone physiology, and also concludes the endocrine physiology section.